back in, and I know I'm never letting this go. There you go, making my heart beat again, heart beat again, heart beat again. There you go, making me feel like a kid. Won't you do it and do it?
Please welcome Chair of the Institute for Nursing Leadership Signature Event Work Group, Dr. Hussein Tahan.
Good afternoon. Good afternoon, colleagues here in the room or attending virtually. I really appreciate the opportunity to chair this event. My name is Hussein Tahan, and as I serve as chair of the INL Signature Event Work Group, I appreciate that Dr. Hickman and General Clara were willing to be so open and transparent about their leadership journeys and professional journeys. One question that I hope everyone will keep in mind today is, how do others see me as a leader? Leadership is not defined solely by rank or tenure. It is defined by the words we speak, the actions we take, how we lift up those around us, and how we present ourselves as honest and authentic individuals. It means admitting when we are wrong, knowing how to ask for help from others, and choosing to be courageous and live with integrity. It means upholding our values as well as the values of those we serve and the values of the profession. The Academy's organizational values include equity, diversity, and inclusion, integrity, inquiry, and courage. The themes of today's sessions and the speakers who have been invited to serve on them encompass these values indeed. Earlier this year, when we began planning this event, it became clear to us that we need to design the agenda and the intended outcome of preparing the participants today to take action. As Dr. Sullivan Marks noted, we are shifting from conversation to action. It is through our conversations that we identify the who, what, where, why, and most importantly, the how. To answer the question of how do we, as nurse leaders, work to achieve health equity, we will now move to the dialogue portion of the conference. Through 2 consecutive dialogue sessions, we will hear from 6 individuals as they share their experience on methods and strategies for advancing health equity, both locally, globally, and regionally. First, we will hear a conversation by an incredible panel titled Health Equity in Action. Each of the panelists will draw from their experiences to demonstrate how nursing leaders can take actionable steps to advance health equity for communities who have been marginalized or have unique needs that require better access to care. I will now turn it over to our moderator for Dialogue 1, Dr. Jacqueline Dunbar-Jacob, who also will serve as a member, who has served as a member of the INL Signature Event Work Group. Thank you, and please join me in welcoming our panelists this afternoon.
Thank you, and good afternoon. I'm Jackie Dunbar-Jacob, and as Hussein said, I serve as a member of the INL Signature Event Work Group. I'm very pleased to be moderating Dialogue 1, Health Equity in Action. During the next hour, I'll be facilitating a discussion with 3 nursing leaders and advocates who work intimately with communities and patients with specific healthcare needs. During the conversation, our speakers will not only describe the unique challenges faced by these communities, but what we can all do as nursing leaders to ensure more equitable environments for them. What I find so compelling about this particular group is that when we had our initial planning call to organize this panel, we quickly realized that although Dr. Linda Schwartz, Dr. Tonda Hughes, and Dr. Lauren Clark each had invited and invested in their careers in a different patient population, there's actually quite a bit of overlap when it comes to patient identities and the barriers that they face in accessing care. The other shared reality of their work is that diversity is not always visibly seen. The patients they serve often face issues related to privacy, stigma, and discrimination in isolation. Because of this, we're centering this discussion around what we can do to advocate, whether within our institution, in our communities, or before policy-making bodies, to bring real change to those we serve. Dr. Linda Schwartz is a veteran healthcare consultant and a US veteran. She previously served with the United States Air Force during the Vietnam War, and her subsequent service led to several highly esteemed positions within the US Department of Veterans Affairs, as well as serving as the Connecticut Commissioner of Veterans Affairs from 2003 to 2014. Dr. Schwartz is currently the chairman of the steering committee for the VA's National Vietnam Veterans Mortality Study and chair of the Academy's Have You Ever Served National Advisory Committee. Dr. Tonda Hughes is the Hendrik H. Bendixen Professor of International Nursing and Associate Dean for Global Health at Columbia University School of Medicine. She is also Executive Director of the Center for Sexual and Gender Minority Health Research in the School of Nursing. Dr. Hughes' research focuses on women's mental health and substance use and is recognized internationally as a leading expert on sexual minority health. She is an advocate for greater attention to sexual and gender minority health within nursing and within other health professions. Tonda, thank you. And Dr. Lauren Clark is the Shapiro Family Endowed Chair in Developmental Disability Studies and professor at the University of California, Los Angeles. Using participatory research methods, she partners with people with intellectual and developmental disabilities to understand their health-related quality of life goals. She developed a psychometrically sound 16-item health-related quality of life measure that notably is used by the Special Olympics to assess athletes' health. As an educator, she emphasizes the pivotal role of nurses in humanizing care and in supporting self-advocacy of people with disabilities. And I'd like to start now by asking Lauren to start us off with a bit more background, and then we'll pivot to Tonda and to Linda, and then to our open questions.
Thank you so much. It's nice to be here today, and what I'd like to do is talk for a minute about what it looks like to raise the bar to try and achieve radical inclusion of people with developmental disabilities in our research and their full inclusion in decisions about their clinical care. So I thought I'd start out with a story, and this has to do with the race that's on to find some sort of pharmacologic aid that would raise the IQ of people with Down syndrome, for example, raise IQ by maybe 5 or 10 points. And if we could find such a drug, it would be very interesting to know if raising IQ by 5 or 10 points increases or decreases quality of life. And I think the assumption by many of us who don't have a developmental disability is if we could cure that impairment, or if we could raise IQ, we might be well on the way to health equity. But I think it's really an ethically compromised position to go there. So I just wanted to flash up here for a minute this information from the National Institutes of Health. They have a research priority. This was published some time ago. And it said there's an urgent need to identify outcome measures, particularly health-related quality of life assessment tools for children and adults with intellectual and developmental disabilities, because the NIH is really smart. And they said, let's find out if raising IQ happens to coincide with raised health-related quality of life, and we need appropriate assessments to be able to do that. So where I lived, we got together and we were talking about, could we respond to this call? And we got in touch with some pharmacologists who had also seen this call and were really excited about it. They said they were already hot on the trail of a new drug that might be able to do exactly, what had been considered raise IQ. And so when we got together to talk about, might it be possible to measure then the outcome, not the IQ as the outcome, but did we really change the quality of life of people? It was just fascinating to me. We went around the room and said, well, what background do we have here? What skills and potential do we have in this very room to address this question? And one of the pharmacologists said, well, I saw a person with Down syndrome at church. And that was the beginning of my education, to realize that as nurses, we happen to have a lot more clinical experience with people with Down syndrome, for example, and we can actually do a lot to help inform the development of appropriate measures. And so we discovered that it was the nursing team that was going to be leading this effort. I have to say that as much as I appreciate the NIH research priority, they never funded our work, and it was done with a lot of sweat equity. But I'm very proud of it all the same. Let me just say that we went on to begin to think about what would it take to have a participatory health-related quality of life measure that people who, part of the disability is decreased critical thinking and conceptual ability, and how can we measure health-related quality of life given the characteristics of the population. And let's see here if I can advance the slide. This is an early version of the health-related quality of life IDD tool, IDD standing for intellectual and developmental disability. And we were aiming to get a tool that asked questions that were understandable, potentially readable for people that could read. And then we wanted to be able to quantify that Likert scale from never, rarely, sometimes, most of the time, and always with something tangible. And we went through a variety of different response formats. We did steps, we did buckets, we ended up with glasses, fluid-filled glasses. And we did a lot of cognitive interviewing and testing, and we ended up including hundreds of people with intellectual and developmental disabilities, both in understanding what was their experience of quality of life and also what response formats worked for them. And let me just show you a video here. This is my son. I was really interested in this question because he has a significant intellectual disability. And I wanted to, as a nurse, know if any of the interventions we tried moved the needle on quality of life. But as a mother, I wanted to know if we could fully include people with developmental disabilities in our research to answer that question. So let me play the video for you. That was fast, was it not? Let's see if we can go back. I may need help from, I'm not sure that I have the arrow to push this. How do I push the go button here?
It was not given to us as a video, so I think we just have to slide.
Oh, the video didn't come through.
It didn't come through.
Well, what a shame. Let me just tell you what my son did. He was a pre-tester, and he was magnificent. The only question he asked after he took part in the pre-testing was, where's my $20 Amazon gift card? So he was very savvy about that. But I asked him if he could respond. Did he like, you know what cognitive interviewing is. Could he read the question? Could he rephrase it and tell me what he thought it meant? And what would he choose as a response? And it was just really wonderful to include him and 225 other people in helping us pre-test and work on these measures. So really the moral of the story here is that there's an adage in disability, the disability world, nothing about us without us. And that's a really pretty serious statement. And I really love to show this picture because it says that we can picture and imagine all the people with developmental disabilities in our lives. We're, as nurses, I think, more exposed than, say, the pharmacologist who thought maybe she had seen one person with a developmental disability. And I took this photo from the PATH PWIDD website, which is run by colleagues of ours, Beth Marks, Suzanne Smeltzer, Sarah Ailey. They run an ACL-funded program to develop better curricula for all of our nursing students. And I think nothing about us without us sums it up. And I think that's where we start in terms of this radical inclusion in our curriculum, in our research studies, and in clinical practice.
Thank you, Lauren. Tonda?
Thank you. I was told the slides would show up automatically, and that's not happening. There we go. Hello, everyone. My name is Tonda, and my pronouns are she, her, and hers. And I'm really happy to be here today to talk with you about nursing's role in advocating for and increasing equity for sexual and gender minority people. And I use SGM as an acronym rather than the ever-expanding LGBTQI, which means lesbian, gay, bisexual, transgender, queer, or questioning, and intersex, and sometimes we add in an A for asexual. So some of you may think that, we're talking about equity, about a lot of different groups for whom we need to advocate for. And some of you may think, okay, same-sex marriage passed in 2015, and aren't things better? Aren't things okay for sexual and gender minority people? But do you know the year after gay marriage passed, more than 175 anti-LGBT healthcare laws were proposed in 32 states. So we have a lot more to do. Health equity, in case you all are wondering what that means, is the highest attainment of health for all people. Health equity is not the same as health equality, as this diagram or this image portrays. You can treat people equally, but that's not going to be equitable treatment. When I talk with nursing students and practicing nurses, they will often say to me, I don't discriminate. I treat everybody the same. And again, as this image illustrates, that's not what we want to be doing. If you treat people the same, if you treat SGM people like you treat heterosexual or cisgender people, if you don't take into account their unique needs, we really aren't providing equitable care. And as a result, I'll share some statistics. 56 to 70% of SGM people have experienced some form of discrimination in health care. 28% of transgender and gender non-conforming people have postponed health care when they're very sick or even injured due to discrimination and disrespect. And you may not be surprised to hear that sexual and gender minority people of color are more than twice as likely as white SGM people to avoid health care. So about a fifth of transgender people have actually been denied health care. And can you imagine, just try to put yourself in the place of going to seek health care and being refused just because of who you are. So most nurses would never discriminate. Most nurses would not discriminate intentionally, but mostly we do it because we don't understand, we don't have enough education. So I'm going to show you a video with some examples. And unfortunately, I could find nothing for nurses. It's all about physicians. So when watching this video, think nurse, not doctor.
Are you a doctor? Do you wake up every day to save lives? Then this message is for you. Many well-intentioned doctors like you make LGBTQ patients uncomfortable without even knowing it.
Well, I don't see a need to prescribe you with birth control today since your partner is also a girl.
Oh, okay.
Okay, moving on.
It looks like I just saw you last week for your hormone therapy. It's too soon for your next treatment.
I just think I have strep throat.
Oh.
So what is your sexual history?
Well, I'm currently having sex with both males and females.
Oh, so you're bisexual.
Well,
How does your boyfriend feel about that?
Okay, so let's get these forms taken care of. Charlotte, 15, female.
Actually, I go by Charles, and I'm non-binary.
Yes, but your medical form indicates that you're a female, and it'll be easier to address you in line with your gender markers for medical reasons.
I see on your forms that you're homosexual. Would you like to schedule an HIV test? Gay males are at a higher risk for HIV than heterosexuals.
I'm not sexually active.
Side effects of judgment, assumptions, and labeling in doctor-patient relationships may include shame, depression, lack of trust in doctors, gender dysphoria, and a lowered quality of life and care. We're doctors, and we know medicine, but we have to know our patients too. Trust and respect are as necessary as the right diagnosis.
So the takeaway here is educate, don't discriminate, or educate so not to discriminate. Thank you very much.
Thank you, Tanda. Linda?
I think I have a slide, but maybe it was just one. There it is. These are my people. I served for 16 years in the United States Air Force, both on active duty and as a reservist. And I served during the Vietnam War. And I was actually stationed at a battle casualty staging area in Tachikawa, Japan. So we got the casualties coming right out of Vietnam. They stayed with us so they could be stabilized so that they could make the long journey home. And I wanted to be a flight nurse. That I'd read about it when I was in high school, and that's why I joined the Air Force. But actually taking care of the casualties was a very important lesson because you learn firsthand what is the cost of war. And I was 22 at the time I was taking care of these young men who were almost my age. And as I continued in the military, I was able to actually become a flight nurse and spent a lot of time in the European theater with a lot of experiences with urgent missions to actually airlift. We were not at war at the time, but to airlift people who were injured. And then I got married. That was allowed, but if you were going to have a child, you had to leave the military. And that was known up front. So my husband stayed in the military, and actually, when we were stationed in Germany, and when I came back to the United States, I was able to join the reserves at McGuire Air Force Base, to be able to work with a lot of people that I knew before. And then in 1983, one day I went out on a mission, and the door of our aircraft blew off at 30,000 feet. And I was thrown through the cabin and ended up with decompression sickness of the brain and spinal cord, and literally that was the end of my Air Force career. So, but it was also the beginning, and I am one who believes that you go where the work takes you, where you think you can do some good. And it may be at the PTA or it may be at the VA. But having to go to the VA was an experience unto itself, because that was back in the 1980s, and a lot of what the VA is doing now is because so many of us spoke up. But at my first time I was at the VA, I was put in a room with 3 men. You remember that scene in Snow White where she wakes up and all these men are around her? That's how I felt. But I really saw, even though I was injured, I saw with a nurse's eye, this could be a lot better. And so I started just actually working in my community. And then I was asked by a group of Vietnam veterans to came over to our house and asked. They said, you speak veteran, and we trust you. But we don't understand some of this stuff they're saying to us at the VA. Because at the time, America wasn't where it is today, and I'm proud to say that I think that Vietnam veterans had a lot to do with that, and we're still working on it. What happened was, thank you. We have a saying in the Vietnam veteran community, never again will one generation of veterans turn its back on another, and we mean it. So we're still up there working with the burn pits and trying to help with some of the problems that the veterans are having with their children because of the exposures that they endured. But for me, I would just like to say that you have to remember why it is you chose nursing. And when I look at these figures and the people on the wall, I wanted to help people. But I also was I was fortunate enough to have the voc rehab program. I went to the Yale School of Nursing. I thought as I was going through that experience and my doctorate that I am getting more tools to help us slay the dragons, the problems that are going on, and in the VA, and especially for women. It was very, very difficult for the longest time, but now we have come almost full circle. We still have a lot of work to do, but that is the issue. You can see, thank you. You can see here that the number of people who have served in uniform, it's growing, it's continuing, and it is a dynamic process whereby everyone, including the VA, has to get with the program. That's a military term, get with the program. But so much of the bureaucracy is a challenge, and that's where I found that the fact that I had an education and they trusted me. You have to listen to the people you're going to represent, your constituency, but at the same time, you have a lot going with you. Yes, I speak veteran, but I speak multivariate analysis. I speak chi-square. I speak truth. And that is that, and it doesn't stop, because the problems emerge, and you just want to do the very best you can because of all of the sacrifices people have to make to serve our great nation. So that, in many respects, is why even now I am still battling some of the problems with Agent Orange and working with younger generations with the burn pits. But there's the bureaucracy of, I will just give you an example, military sexual trauma, okay? Well, if you are the VA, the definition means not only assault and rape, it means harassment. But if you try to talk to the fellows over on the other side of at the Pentagon, their definition is not sexual trauma. It has to be hands-on. Someone has to have touched them. Someone had to have done something to them, or it's not in the same arena. But when they are discharged and they are coming out and looking for people to help them. So even getting the the definitions between the two agencies. I know they're working on it, and I'm very pleased to see that. But what I wanted to say is that it never stops. I don't have to think about all the things they gave. I just have to think that they deserve to have the very best, the absolute very best that this nation can afford and give, to be sure that they are taken care of and their families are taken care of. I will just close with one other thing. I was interviewed by a French journalist, and it was on television in France. So we had to get somebody from my staff to translate for us. But after coming through I was commissioner for 11 years, coming through our facility, they said, of all the nations of the earth, America takes the very best care of its veterans. And that's because America has been blessed so many times over with the men and the women who actually step forward and defend our freedoms. They deserve the very best.
Thank you, Linda. So each of you have clearly had strong advocacy positions and success with those positions in the work that you've done with each of the populations that you've worked with. I wonder if you could each tell us how we could raise the bar to continue our advocacy efforts with these and other populations to improve the quality of care. Lauren, would you start?
I would be happy to start. You know, and it seems sort of trite to say it, but I think we have to start with educating nurses as they are coming into their own as a professional and kind of donning that mantle of nursing professionalism. And so we start where I am pretty early with that ethics course, the first ethics course, and we have a whole week on humanizing care for people with disabilities. I think because I teach the course, I made sure that got in there. But there's something about that, right? Humanizing care for people who are gender and sexual minorities, or humanizing care for veterans. How do we create a space that's not just technically adequate, but that recognizes the humanity, the dignity, and affords the respect that's really important to make care the best on earth in lots and lots of different ways. So I have to say it starts with the beginning of education.
Tanda, what would you recommend?
You know, education, as I ended the video, I think is absolutely key, and how lucky your students are to get a whole week about people with disabilities. There's been a number of surveys done, and one national one and a lot of the smaller ones have found that nursing programs include about 2 hours of education across the board related to sexual and gender minority health. It's not nearly enough. I cannot fathom, and I've asked this question of many audiences, I've thought a lot about, why are we as nurses not taking the lead in this area? I mean, we of all people should be taking the lead. It wasn't just the videos that I wasn't able to find anything about nurses. Medicine, psychology, public health, they're all ahead of us in terms of advocating for and caring about, working on the curriculum related to this issue. So that's definitely one thing. And then I mentioned that 175 laws were proposed in 2016. Well, in this year, 250 anti-LGBTQ laws have been proposed. We have to do something. We have to reach out to our representatives and Congress people to let them know what we think. I mean, some of you may agree with some of these laws that limit, you know, life-saving, gender-affirming care for transgender people. A law that Arkansas has passed that also gives healthcare providers the right to refuse care when they disagree on moral or religious grounds. So there is a lot that we can do, and I just would love to hear from you at some point, if we have time, why you think it is that nurses aren't stepping up to the plate, aren't getting with the program. Thank you.
I think nurses, and you're right, it starts when they start in the profession, You should never underestimate the power, the innate power that you have as an expert not only of nursing, but of humanity. And that when you move forward and see something that you are interested, just like you, do not let it pass you by, because you have to go where the work takes you. And if it's something that you are vitally interested in, don't stand in the back of the room, because nursing is respected. It is more respected in the legislative arena because we speak the truth, along with multivariate analysis and chi-square.
That's great. So how do you see the successes that you've had in your advocacy efforts translating to the rest of us? I'll start again with Lauren.
Oh, that's interesting. Where do we start, right, as individuals? I'm going to just think for a moment about some work we did with families who welcomed a child with a developmental disability into their family. And I know with prenatal genetic screening and testing, not all families make that choice, but these families did have a child with a developmental disability. And we did research with them and followed with grounded theory 40 families, 40 parents, or more than that, parents who talked with us about what it took to make sense of this unexpected news, because no one had thought from their childhood they were going to grow up to have a child with a disability, and here they were. And it was a very difficult time for these parents. And they said what made a difference was the nurse or the social worker or the chaplain or the physician who kind of broke the bounds of that demeanor of professionalism and sat with them and said, this is hard. This isn't bad news, but this is hard news. And they told stories. They could recount word for word what the nurse said that made a difference. And Brian Scotco at Harvard calls those flashbulb memories. And those flashbulb memories were stored away word for word in parents' minds, and they could draw them up over and over again as they began that sense-making journey. And sometimes it was the nurse that said, what a wonderful, wonderful baby you have. This child is going to make a difference for you, for your family, and for society. And something as affirming as that, something as hope-filled as that, was just the tagline that a parent could hold on to. And I think sometimes it's important for each one of us to realize that we can dig deep into our own humanity and make a human connection. It takes a leap of faith that we can do that and not transgress boundaries or insert an unwanted dialogue, but just to reach a comforting hand of hope and possibility. And again, to set the bar high, that we can expect a lot of people with developmental disabilities. It's not a tragedy, it's not pitiful, it's just simply a different way of being. And to open parents' eyes to that possibility is something every one of us can do.
Tonda, what would you add?
Yeah, individually, I think I advocate by being a nurse researcher. I've been doing work in this area since the early 1990s. And also along the way, I've mentored lots of younger, newer people in the profession to do this work. And I do think things are getting better. But it's not nearly enough. There's not enough nurses doing research. There's not enough nurses who are including content in their curriculum. And I think we have to do a lot better than we are doing now. I think with the new generation, things are changing. People don't see sexual and gender minority people as being different. Many of our students don't see them as being different, but I do think there's a lot that we could do. And just for a couple of concrete examples, the people that I've mentored and I have written a couple of papers. One reviewed the top 20 nursing journals over the past 9 years. And we found that less than 2% of all articles in those nursing journal articles talked about or addressed sexual and gender minority health. from a research perspective. And that was hardly any increase from an earlier review that had been done. We also did a review of the National Institute of Nursing Research funding for sexual and gender minority health research since its inception. And since 1987, they funded, as of the time that we wrote the paper in, say, 2019 or 2020, they had funded 25 studies of sexual and gender minority health. Most of those were F31s, and 58% of those focused on HIV or AIDS. The relatively few studies that were at our level, I think it was 93 or more % focused on HIV and AIDS. So we need, when you're teaching about these topics, you need to move beyond sexually transmitted infections. If you're teaching maternal child, pediatrics, family health, public health, geriatrics, it's applicable there, and you don't have to add a whole course. You can just incorporate the content, and that's what I think I've helped my colleagues to do. So thank you.
Thank you. And Linda?
I think sometimes nurses, if they're practicing at the bedside or in academia, sometimes you're working so fast and so hard that you don't really step back and just take a moment to look at what nursing is. You know, nursing touches every single part of the human experience. We are trusted, and we are healers, and we are confidants. And part of what it means to be a nurse is to take those things that your patients need, that your community needs, and not be afraid to flex the full power of that greatness and that power that comes with being someone who knows. I used to have a friend, I have a friend named Teresa Hendry. She said, if you can talk a patient into taking Metamucil, you can talk a legislator in just about anything. That gave me a great deal of strength, and so I began, and the truth of the matter is the truth. Sometimes that is very missing, but as someone who comes with a title of nurse, they expect truth. They expect you to be tuned in to humankind. And I believe that that is the great power and the great beauty of what we do as nurses.
I'd like to take just a moment to encourage you to submit your own questions to the panel. We do have one question at the moment, and that has been directed to Dr. Hughes. How can nurse-driven awareness and education influence the public to deplete stigma around SGM access to care?
Could you read that again, please?
Yes, I would. How can nurse-driven awareness and education influence the public to deplete stigma around SGM access to care?
Well, I think if we educate nurses who then are role models in caring for people in healthcare settings and people in general, we can make a huge difference in the public's opinion of those people, because as we've said, nurses are the most trusted profession in our country and in many other countries. So just by being a role model, by treating people with respect, I think that we can help to reduce stigma. And I do see stigma as the biggest barrier to providing equitable care for sexual and gender minority people and for other historically disadvantaged groups. It is the thing that we have to deal with, and by talking about it in these forums, I think this is a really important first step. I've been so impressed by the people who've spoken already. It's a little intimidating, actually. So with all of you, we can do anything. Dr. Nelson said, if nurses decide they care about something, they can do anything. And I believe if we care about this topic, that we can do anything. We can make change. Thank you.
And there's a question for Linda. Linda, can you share some insider baseball on how to get our policymakers to listen? You talked about going to policymakers and have been effective in doing that, and we would love to have some tips.
I would say collaboration. One of my greatest hopes and prayers was to get the veteran community and the nursing community together, because that's a dynamic duo, and to have veterans give the information to the nurses. Not only that, but you know your own communities, the disabled. But I wanted to say one thing too. Do you know that the American with Disabilities Group, the association, they don't count the 6 million veterans who are disabled. They don't count them. We asked them why not. Because we don't have to care about them. That's what they said. So we have to make them care about them, and it's going to be more and more important as we go further into it. But I would say collaboration, and also, I don't want to say have no shame, but if you really care, sometimes you can present I'll just say my two sisters say, Linda, you can't even ask for somebody to pass you the salt at the table, and you're up there talking to the president. But the truth is, you transcend your own frailties because of your belief in affecting good and making sure that your patients are spoken for.
And now I wonder if each of you could give us some strategies for better preparing the workforce early on to be advocates for all of the special populations that we are and that we have in nursing.
I would love to answer that, if I may. I don't know if you're all aware, but this month is National Disability Employment Awareness Month. And I'm really proud to say that at UCLA, at the School of Nursing, our new dean, Lynn John, has made a commitment to hire an individual with a neurodevelopmental disability to be in our nursing skills lab. And that person is specifically there to do two things. The first thing, of course, is to help nurses learn skills. And this person will help with check-in. We'll make sure that the students have their COVID mask in place, and we'll take care of the mannequins, and we'll do some other things in the lab. It's kind of an entry-level position. But the second purpose of that position is to, and this is the surreptitious part, to give the nursing students the chance to work with a person with a developmental disability as a member of the healthcare team. And I think that's the whole point of National Disability Employment Awareness Month, to give people meaningful work, not give it to them, but give them a supported but inclusive workplace. Healthcare is a terrific place. It's what, 14% of our economy. And I think we need to, as nurses and as people in the workplace, be more adept at being able to work across ability and disability differences. And I'm thrilled and excited that the Nursing Skills Lab is a place where nursing students will have that first and ongoing contact. They won't be able to leave school and say, I think I saw a person with a disability once at church. They're going to be able to say, I've worked with a person with a disability, and I have some skills already in hand.
Terrific.
Tonda, do you have additional thoughts?
Yeah, I think Skills Lab and Simulation is a wonderful place for teaching about all of the populations that we've been talking about today, because it provides a safe place for practicing before people go out into the real world and make the mistakes like you saw in the video. And although I'm not quite sure this is answering the question, I wanted to leave you all with just a few really simple things that you can do to advocate for sexual and gender minority people, your students, your patients, your colleagues. If you wear a name tag, put a little rainbow sticker, a equal sign equality sticker, a pink triangle or something on your name pin. Something as simple as that makes a world of difference to people who are sexual and gender minority. It doesn't take much effort at all. Consider introducing yourself to your students using your pronouns. That then provides them a safe place and an accepting atmosphere to share their pronouns with you. Include them in your email signature. Put them in your Zoom talk. I've actually been campaigning, maybe that's too strong of a word, but to get Columbia nursing faculty to do these things. And I'm making some progress. So if all of you did that, I would feel like I'd made a lot of progress. So consider doing some of those simple things.
And Linda?
I think that nurses are good teachers in every arena of life. But also, I think sometimes we have to challenge the status quo as well. And I think nurses are pretty good at keeping focused on where they want to go with things. But for example, I knew very little about this. So, but I knew people who are of that ilk, and I asked them to explain it to me, because I didn't understand this, him, hers, and that. And so once you understand it, then you think, uh-huh. So I think, and my daughter and I were talking about this because we were not sure what letters were being used now, but we asked someone who would tell us. And I think that's another thing, having people who are of that community being able, same with veterans, to have them get up and speak about what it is to be who they are. And they become the teachers.
You know, Linda, that's so much, nothing about us without us, that could be applied way beyond the disability community, to have that dialogue. Yeah.
And for SGM people, the slogan is, you can't treat me unless you know me. So unless you ask questions to find out about who the person is in front of you, then you really can't provide person-centered care.
And you have to see it as part of your responsibility as a nurse, that this is a person, a spirit, a living being, and I'm going to be the nurse. I really do feel that's what kind of gets you going on these paths.
And you don't have to be to believe that it's right for, you know, the right thing or the moral thing. You just have to be open to learning and to respecting the person, whatever their identities and choices are. So.
We have a question for Lauren. Lauren, how can we increase coordinated care in all aspects of life for those with disabilities? For example, education, housing, healthcare, and so on.
Oh, that is such a great question. You know, there are, of course, different laws and policies that have to do with developmental disability and veterans and disability later in life and different kinds of disability. And one thing that strikes me over and over again as I continue to do research and teach is how many different definitions we have of disability and how definitions drive reimbursement strategies and how diagnoses may or may not be counted in definitions. So it's a really complicated area. And I think thinking about care coordination, that's a really tough thing to do, but I suppose it does go back to what Linda's saying, this idea of assessment and inquiry, and how can we ask people what they need? And we may not be really great at helping people navigate, for example, the education scenario, getting through an IEP, because we're nurses and we're not in maybe that setting as much as, well, maybe a school nurse would be. But I think we can ask those questions and we can begin to do what all good public health nurses do, and that is referral, case finding, and trying to coordinate from where we stand. So, you know, I wish I had a really good answer for that, but I think it's probably what you already know, and that is just continuing to do the good nursing work, that using those same principles that we already know.
Well, I think we're near the end of our time for this particular dialogue. And I believe, and I hope you also do, that our panel has both given us reasons why we need to be advocates for a variety of individuals that we see in our realm of care, and also some very important tips on how we can actually do that. So please join me in thanking the panel for their wonderful advice. Thank you. Thank you.
Thank you.
And that brings
welcome co-chair of the Institute for Nursing Leadership Signature Event Work Group, Dr. Janie Heath.
Good afternoon, everyone. Hope you enjoyed our first Health Equity Dialogue. My name is Janie Heath, and I serve as the co-chair of the Institute for Nursing Leadership Signature Event Work Group, and I am also the Dean of Nursing at the University of Kentucky. As we prepare to hear from nursing leaders residing abroad, I want to acknowledge that we have incredible nursing leaders and fellows who live outside the United States. As you all know, we have much work to do here domestically in the U.S. when it comes to advancing health equity. And we can't forget that our colleagues abroad are working towards the very same endeavor. The Academy's mission is clear: improve health and achieve health equity by impacting policy through nursing leadership, innovation, and science. Building off of this organization's strategic plan includes the goal of positioning nurse leaders to advance local and global change. We are to achieve this by focusing on 4 key areas: strengthening the Institute for Nursing Leadership support for nurses to meaningful exercise that power at every stage of their career, fostering the growth of authentic leadership among nurse leaders, leveraging opportunities to raise perspectives that elevate nursing and the Academy's inclusivity, and developing thought-provoking, innovative programming to simplify and amplify the contributions and collaboration of Academy Fellows. With this in mind, the Institute for Nursing Leadership National Advisory Council has taken a keen interest in ensuring we all are amplifying the voices of all of our fellows in our efforts to make real change locally and globally. The next dialogue session underscores how the vision of healthy lives for all people takes shape across 3 different countries and regions. Given varying infrastructures, cultures, economies, and health delivery systems, health equity looks differently around the world. Now I would like to introduce our 3 panel speakers who are joined by Dr. Hussein Tahan as the moderator. First, Dr. Nassima Al-Qasir, who is the representative of Egypt and Health of Mission for World Health Organization. Dr. Al-Qasir has over 30 years experience at country, regional, and international levels in the area of health systems, humanitarian, and development to protect health and health security accountability. She is one of the first change agents in her organization to set the transformation vision based on creative work achieved in complex conflict settings, and has been engaged in COVID-19 preparedness and response in Egypt. Second, we have Dr. Patrick Palmieri, who is the Director of Evidence-Based Care in South America and Senior Research Scientist, South American Center for Qualitative Research, and Universidad Norbert Weiner. After serving as the Dean of the School of Nursing and the Vice Chancellor for Research, Dr. Palmieri transitioned to lead the newly formed South American Center for Qualitative Research. He is actively engaged in research focused on areas with individuals living with HIV/AIDS, reproductive health, and chronic disease management. And third, we have Dr. Erlinda Peleganes, who is the Distinguished Full Professor in University Science of the University of the Philippines, Baguio. And evidence for the work that she does is her work to advocate for nurses and people's welfare. Dr. Peleganes is largely known among the Philippines community health nursing as the leading expert in qualitative research and in her contributions and sustained efforts to achieve equitable access to healthcare for Filipinos. Please enjoy the session and thank you.
Good evening, everyone. My name is Hussein Tahan, and it is my utmost honor to moderate this session of our INL signature event, Dialogue 2, Global Perspectives on Health Equity. I know you would agree with me that health equity, although a common goal in nursing and to nurse leaders, it looks differently across the globe. And our influence as leaders varies dependent on the local or regional context. In this session, nurse leaders from 3 different countries and continents will share with us how where they serve shapes the environments they navigate in advancing health equity. Despite the differences in geographies, cultures, health, and human service delivery systems, infrastructures, professional assets such as mentorship, influence, trust, deliberate leadership, knowledge and expertise, resourcefulness, and impactful collaboration with key stakeholders are critical to this endeavor. No matter where the Academy members are located, we are for sure all united under the common vision of healthy lives for all people. Joining me in this session are 3 esteemed nurse scholars and Academy fellows who have made a great impact, not only in the regions they serve, but globally as well. Dr. Naima Al-Kassir, World Health Organization representative to Egypt and head of mission. Dr. Erlinda Castro Peleganes, Professor of Management at the Institute of Management, University of the Philippines, Baguio. Dr. Patrick Palmieri, Vice Chancellor for Research at Universidad Norbert Weiner in Peru. You may refer to a summary of their background and expertise on the Academy's website, especially on the page that's dedicated to INL's signature event homepage. Sincere and warm welcome to our panelists, so let's get started. Perhaps we can start with exploring the meaning of health and health equity. So Dr. Al-Kassir, let's start with you. And my question is, what do these terms mean to you personally and those that you serve? Also, please, while you're addressing or sharing with us the meaning of health and health equity, address the role of nursing in ensuring the more vulnerable people have access to the care they need and deserve. So I'll turn it over to you, Dr. Al-Kassir.
Greetings from the land of civilization, from Cairo. Thank you very much for American Academy of Nursing to be inviting me to this panel. And thank you, Dr. Hussein, for your moderation and really laying out the way forward. Health is a right, and it's a human right, as is the core constitution, and it is actually throughout something that we must enjoy. Health equity, looking at the lens of respecting humanity and human being, regardless of their gender, regardless of their status, regardless of their social or geographic presence. It is a concept that we have taken an oath as nurses to deliver care and protect people's health regardless of who they are. And to me, this has really been enshrined in our nursing education. So for me, as a nurse who have been believing in the instruments of the human rights, taking the oath that I will give care to every individual human being, regardless of their color or race or status or political affiliation or orientation, I have to say it's something that will be continuously guiding us. Health equity is actually looking at the gender, men, women, young boys, young girls, newborns, regardless, to be given the care. Equity means that we are looking also at from the lens of justice to protect the health of every human being. We do in our work, we are working in various settings, and we are seeing the various colors of the population. For me, equity means a practice, a principle that we translate to a practice on our daily talk, daily walk, and at the same time, continuous delivery of our service, regardless of where we are, regardless of which parts of the world we are. So that's for me what it means, implementing the rights, but practicing actually what we are preaching. Thank you.
Thank you. Dr. Palmira, perhaps you can share with us your thoughts on the same question, the meaning of health and health equity to you, and how we, in Peru and where you practice, able to make a difference for the people we serve there.
Yeah, and in a more pragmatic perspective, when we speak about health equity, for me, it's about actionable items, actionable work that I can undertake, that I can help other people or stimulate other people to undertake, and to help other organizations understand is important for bringing folks that don't currently have health services that are at least good quality and accessible to our table. And so for me in Peru, the goal, because we have a Ministry of Health which services the vulnerable populations, we have an S-Salute system, which is a social security system, which services all of the folks that are workers. And then we have the private system. And so for me, it's trying to move the public system and the worker system to be more like the private system, where there's international accreditation and other sorts of mechanisms which bring high quality healthcare to the wealthy populations. And now it's my job as a nurse, my responsibility as a nurse, to help these lower levels of health services. And I say lower levels because they don't provide the same quality of care and the same accessibility, to bring them up to the level that I enjoy in the private health system. So from a pragmatic perspective, what we need to do is bring these tremendously healthy private systems in many of the countries, whether it's Egypt, the Philippines, or Peru, or the United States, into equity with the systems that the other people use. And I say other people in such a way that we need to recognize that that vulnerable people are other people, because they're outside of this wealthy, high-level health system that provides this high-quality care. So that's how I would pragmatically define health equity, is bringing the private system and the very poor public health systems to some sort of meeting point. Thank you.
Excellent, thank you. I'm going to turn it over to Dr. Palaganas. Any perspective from the Philippines?
Thank you very much, Naima and Patrick, for your perspective. I couldn't agree more. You've brought health and health equity into a very dynamic perspective. And on my part, I would like to say that I'd like to put it in a more, how do I say this? At the perspective of people on the ground. You know, every time when I do research and I ask farmers, fisher folks, and laborers what to them is health, they would always say, for as long as I'm able to go to work, for as long that I could provide food for my family, you know, all these simple things. They don't talk about biological causes. They don't talk about, you know, highfalutin things about, you know, about health. But to them, that is health. For as long as they are able to go on with the daily activities of life. And that to me is very crucial because it's very simple. It's simply put, what health is. And that's health equity, that's health access. And to me, when health becomes, when health is not a privilege, when health is something that every Filipino, well, I'm speaking for my country, that every Filipino have access to, then health equity is there. But unfortunately, it's the other way around. Health is such a privilege. Only those who have the money, only those who would have the economic ability to pay, only them can have access to health. And health is very inequitable in my country. And this is the reason why, as a nurse leader, I started out as a community health nurse because I believe that that is where nurses should be. Nurses should be where the people are, where majority of the people are, where those who have inaccessible, where health is inaccessible, they should be there. And that is why I do I did and I still do community organizing. I organize the people. I train and bring health accessible to the people so that they become self-reliant. Basically, my life as a community health nurse was that of putting health in the hands of the people through community-based health programs. And I still do believe that up to this time, it is the way to go for health equity. Put health in the hands of the people through primary health care, universal health care, community-based health program. Thank you, Hussein.
We definitely agree that to health and health equity, we got to focus on affordability, access. Everybody deserves the services they need, and as nurse leaders, how we make that happen. It's part of our role responsibilities that we ensure that takes place. Now that we established what health and health equity means to you, let's talk about context of care delivery. And we all agree that culture and context are essential aspects of any effort we pursue to enhance health equity. So I know each of you has been serving in an environment that's fraught with complex and real challenges, whether that being limited resources, oppression, corruption, war, racism, or social injustice, and the list goes on. So the audience and I would be interested to hear from you. How have you been able to overcome such challenges, remain true to your commitment, and influence concrete change in the health of the people in the communities you serve? So perhaps this time we'll start with Dr. Palmieri, and then we'll get back to the rest of our panelists.
Well, I think from my perspective, I came from the United States to Peru 15 years ago because I married a Peruvian economist who's quite accomplished, a very senior banking leader in this country at this point. And so I began building with a team of individuals, a team of people, the largest health system in Peru, privately owned. And through that project, we were able to achieve the first international health accreditation of a facility. And since that time, there's been multiple facilities that have accredited, including one public hospital. For me, I've been immersed in improving health equity in the country through projects. Because one of the things I think that fellows can do is they can engage in micro and meso level projects that actually have a direct impact on improving care. My daughter was actually born at the hospital that I helped accredit, the maternity hospital. And that was only possible because of this project that we completed. My eyes have been awoken to the problems that you've spoken about in terms of corruption and all of the things that happen in governments and in communities, living in what is a second world country. And what my role has been is to awaken people to see to give people vision to see these folks that are not achieving what they can achieve in life because of their status in the communities. And I'll give you one firm example. Through research that I did with colleagues from Spain and in Peru as nurse researchers, we were able to find that the folks that live in the provincias of Peru, which is the rural areas or the areas that are away from Lima, which is the Mecca of Lima, because a third of the population is here, these folks living with HIV were actually not receiving the first line therapies that were recommended by international organizations such as the World Health Organization. And the folks in Lima were receiving them. So this is a firm example of where we were able, through our nursing research, to change a reality for a group of people. I mean, only 540 people, but it's still a group of people, to move them to a level of healthcare that other folks have in Lima, which is the Mecca of our country. And so these individuals now are in first line therapy. So their treatments and their management's more effective. Also, we found that there were shortages of medications frequently in the provincias, and we published this information. And guess what? The government obviously responds, because the governments in all of these countries, I'm not going to speak for my colleagues, but they don't like the embarrassment of having publications saying, oh, you're not serving your people. So I want to remind people our research stimulates change because people are shown the reality in hard, cold facts. And so I would just say to everybody out there, all my colleagues, the fellows, that you really can have a strong impact, a significant impact in all of the various countries that we're speaking about today through your research and your advocacy. So thank you for the question.
Thank you. Dr. Pelaganos, would you like to weigh in? Same question.
Yes, Hussein, I would love to. And I'd like to relate some experiences on that. But at the outset, I would like to mention to you that the context of nursing in the Philippines is within the framework that nurses are not valued in my country. And when I say nurses are not valued, we are in that era where both the private and the public sector are not able to see that there can be no healthcare without nurses. The way they value nurses, that is translated to fair pay, that is translated to a humane working condition. It is something that is not really that existent in my country. When I was president of the Philippine Nurses Association in 2019, it ended up with a call to get to the streets, a silent protest all over the country in any form, just to show how we should be valued. And that was one activity that we did. Nurses in the hospitals who cannot get out of the hospitals and join us on the streets, wear black bands and all forms, candle lighting, just to show our leaders, hey, look at us. We are a valuable force and you cannot live without us. And that was one that we were able to do because our very own nursing bill says that the salary, the entry salary of a nurse is salary grade 15. And that was in 2002. It was never given. It was only given in 2019, 18 years after. Imagine, it's salary grade 15 in the Philippines is below $1,000 a month. So look at the value of nurses in my country, very low. I mean, we are not after the money, but you see, you have to value us because we are the ones running the economy. We are the ones running the healthcare system. So that actually is one huge advocacy that I guess the academy and all organizations all over the world should help emerging countries or low-income countries such as the Philippines, or else what will happen will be Philippine nurses from the Philippines will continue to just leave our country and serve other countries, but leaving behind a country that continues to be underserved. And that in itself is an ethical issue. How other countries, rich countries, can avail of the services of nurses coming from countries where their very own country is underserved and lacking services that their people so deserve. So I guess these are things that fellows or the academy can look into, what collaborative efforts can be placed and can be done on this aspect. So I would like to pursue an advocacy that will help value nurses in countries like mine. Thank you, Hussein.
Thank you. And Dr. Al-Kassir, anything you would like to add to the conversation?
Yes, thank you very much. I would like us, thank you very much for both Patrick's and Irina. I really liked 2 points that I would like to bring. I believed in health, not from a sickness, at age of 7. World Health Day at age of 7 celebrated, in my age, celebrated 7th of April, water sanitation. The health inequities that we are talking about, and it was laid out. While I grew, I was always thinking there is the problem with safe water, there is a problem with safe environment, clean environment, safe food, because we did have many, many problems with it. COVID-19 pandemic demonstrated that health inequity is important regardless where you are, rich or poor. And also demonstrated that we need to invest in the 90% and not only in the 10%. Health is not sickness, is not medicine, is not technology, is not hospitals. And that is a lens that we should think as an American Academy Fellow, we need to look at it differently. We need to say how much we are investing as nurses. I'm glad to hear about community health nursing because I come from a background that we started from individual, family, institution, factory before we did the hospital care as a student. And this background helped me to go throughout in my ladder. Challenges that we faced, whether in my own country, initially there was a problem of pay for Bahrainis versus non-Bahrainis, and I come from Bahrain. And this made us, with my networking as a graduate from University of Illinois, with the different entities, to do a quick assessment to show our government that there is no equity. Because the non were getting much more services. So I'm just talking about the inequity from the provider aspect. But also, when I moved and worked with the ministers of health, we realized that the voice of nursing is low. So that's another challenge. You are a nurse, but maybe because you are coming from a certain country, your knowledge is less. The minute they heard from us, we are talking about health for everybody and not sickness, and that we brought the evidence that we are talking about health in terms of enjoyment and not sickness, and we can bring a difference with the communities. So my practice, whether at my own country, later moved to the Ministers of Health Advisor and then to the Senior Scientist for Nursing at WHO, has been always working, and then followed in Iraq, Sudan, and all the countries in the region, followed 3 things. First, to see how can we advocate for the nurse to be around the table because they will bring a difference, but don't advocate that they are nurses going only to do medical care. Advocate that they are there in the communities, working with the communities, working with the individuals sick and not sick, depending on where they are. And then later on, we used as a tool in WHO, it's called Urban Heart, successfully in Egypt. Before that, I used it in Iraq to bring inclusiveness with the lens of equity. What do I mean? That means not only with the policymakers, ministers, and the government, trying to change the policy for water safety, food safety, cleaner environment, but with the local communities on how what I call health as a bridge for peace. Health as a bridge for peace, and it has gone with me until now. Because virus and bacteria does not know the boundaries, and COVID-19 proved that. Virus and bacteria does not wait for stamps and political commitment of each country. COVID-19 proved that. Today, we are having inequities with the vaccine. 90% of vaccines are held by 10 countries. we are having a whole continent of Africa only 2% vaccinated, and this is the voice of nurses now, including healthcare workers, 2% only out of 1.3 billion population. So this is inequity that we are talking. It's not medical services. I would like to bring another lesson for us. An American Academy Fellow can do it. This private-public interaction, what does it mean when it comes to the 90% of the population that are not in the hospitals or healthcare settings for a medical care? How can we shift our thinking and reduce this 10% to be less and not invest on the high technology? So these are some of the facts that I would like to bring to our attention with challenges that we are facing in the countries that are going through change, difficulties, conflicts, wars, and at the same time are having public health emergencies, which is now a pandemic. How can we invest in the health security? And these are some of the things that I think nurses are facing daily at the local level, regional level, and I think we as fellows can really bring its voice of supporting to them. I started from my own, how I got some support and networking very early on in my professional life, which has been continued. Today, I rely on my network. Today, I rely on the information I receive, and continuously the lens of equity is a reflection individually every day. Did we do a job today? Did we really respect? Did we really provide the care? Did we really bring a policy change? Did we really invest in actually bringing a difference in a mentality of a person or a policymaker? So these are some of the things that I would like to bring to us. Primary healthcare was mentioned, but I would like to also bring the social determinants of health, the gender, the equity between men and women, the water safety I mentioned, education, people are educated, the income, already it was mentioned earlier. And how are we going to link it? Are people having something to drink or eat? And I mean, I can go on and on, but these are some of the challenges facing. I just want, if in 30 seconds, I come from a country, quote unquote, considered rich, and I am a nurse and a woman. My first challenge was first within my Gulf countries, because they couldn't believe a nurse can be coming and speaking to the ministers of health, 6 of them then. And I was the first nurse to address the ministers of health to tell them that we need to change. Immediately they told me, you can send someone to speak, just tell us what do you want, don't come and address us. And I said, I can send us our photos, it's not only me, and we can send you in writing, but you need to hear to us. That was my third challenge. As a WHO, when I entered into the UN, the minute I took Iraq over and worked in Yemen, the immediate vision was a woman, a nurse, and coming from a rich country, does she able to deliver? The lens of equity was missed. I was not from a rich country, but that's the perception. But it was a country that's really invested in its human being. And for us, this is time for all us as different in our post to invest in nurses. And that's the word I want to link. How can we invest in the young generation and how we can bring the voices out to continuously reflect, can I give care? Am I really looking from all the angles of equity? Am I really not having this divide of haves and not have-nots? Am I bringing solutions to the table? Thank you.
Thank you. Different perspectives, but in the end, complementary. I love that use research to advance health and well-being, and as Dr. Palmier talked about, value of nursing and working conditions and what nurses can do when we take care of them and elevate their stature, and also looking at equity and the role of nursing in terms of public health and well-being, and going back to the roots where you improve health in the community and what services communities can have. So I love that all of those nurses and nurse leaders can really make a difference locally and globally. We're getting close to the end of the dialogue, but before we open it up to questions from the audience, I would like to ask each of you, just in a 30-second share a defining or inspiring moment in your practice or a word of advice as a final thought to encourage other interested nurses or nurse leaders in getting involved globally and in particular in health equity. So, so let's go back to Dr. Palmieri and any final word advice, if you will.
I think nurses, especially fellows of the academy, need to be more involved globally in mentoring and supporting. The work that I do, and I'm not going to speak for the other panelists, but I'd imagine it's very similar, is very dangerous, very dangerous. I mean, I've been threatened my life. I've been threatened to be destroyed. I've been threatened to go to prison. My house was broken into and everything like robbed. And I know this is all because of my engagement in trying to expose the problems in a rich country with too many poor people. And I just want to tell you, I was interviewed for an article in The Lancet about a major scandal that happened in Peru where vaccines were given to the wealthiest and most important people. Our president was impeached because of this, receiving vaccines through a clinical trial illegally. One of the most heinous, unethical acts probably in the last 10 years in the world in terms of research, okay? That article resulted in a lot of pain and suffering on my part because I spoke about this powerful political class that continues to control the health and equity of the country. So my message to everybody in the academy is very clear. Please don't take for granted what you experience in your OECD countries in terms of the pleasures and the gifts that you have because of where you were born. Number two, please find colleagues in these other countries, whether it's Egypt, the Philippines, Peru, whatever country, to mentor and to protect. And number three, recognize your colleagues in the academy who do this work silently, because they're not the people that are the big names in the academy. These are people that do their work silently and they support us. And in closing, I just want to say, for example, I very much appreciate my mentor, Dr. Jean Watson, for her support, because her support and her guidance and her mentoring has helped me substantially in terms of my development and also in making sure that I was not harmed because of the fact that my voice could be public. So thank you all very much for this opportunity to speak with you all. Thank you to my colleagues for being able to listen to your stories and your experiences. And thank you, Hussein, for moderating this session.
Thank you, and we're glad you're safe and you're with us, and we really appreciate all you do every day. Dr. Pelaganis.
Thank you, Patrick. I mean, like listening to you was like also saying my life. I mean, like I've been through that as well, and up to this time, I go through that fear of that comes with activism. I'm a health activist. I have always been a health activist, and maybe that's the reason why I've never really occupied high-ranking positions, because it has always been me trying to be an alter ego of what is the existing. And once you are that, you are always red tag. It means I am doing something for my people. I'm doing something for the nurses, and that is what I would like to tell my colleagues in the academy. And of course, I would like to thank you to thank the academy for believing in the accomplishments that I have had working in the communities, training barangay health workers or village health workers, barefoot health workers all these years, and marching on the streets for our nurses, and going to the halls of Congress and Senate, working, advocating, lobbying for our nurses. That is the kind of activism that we would want, not to be just in our comfort zones. And that is why I would like to say to our fellows in the academy to continue serving our people, continue serving the disadvantaged populations in whatever populations they are, And at the same time, that I would like to call on our colleagues in the academy to be to walk our talk, you know, live simply, because there are other nurses, there are other people who wouldn't even have a speck of what you have. I mean, our salary, the salary of our nurses here in the Philippines is less than $1,000 a month, and they live by it. So it's like saying that if you live an affluent life, there are nurses all over the world who cannot, you know, enjoy that privilege. So thank you, Patrick, for pointing that out, that indeed mentoring is very crucial. That care we give to the people, we give to our nurses, because once our nurses receive that care, it transcends to the care that they give to the people, to their patients. Thank you.
Thank you. And last but not least, Dr. Alcacer.
Well, thank you very much. I think a couple of things have already been mentioned. I have worked in the most difficult situations between Yemen and Iraq and Sudan and Libya and Tunisia, especially in 2011, including Egypt. So yes, I have been threatened because of my activism. I work both publicly, but also I have my own volunteers. So working with the communities, I learned it from my late Dr. Beverly McElmurray, who used to be a fellow also. She taught me while in Chicago on actually working for the vulnerables, the gender equity. So she has been my mentor, she had been, but also in Lebanon, because I studied at the American University of Beirut during the war. What it taught me to be risk-taking, mitigated risk, always had more than one scenario. Lebanon prepared me for Iraq. I was called Naima with 5 scenarios, because I would see to protect myself, not as a nurse, but as a person who is trying to deliver and service to others, protect my team, but at the same time work with the communities. So that's one thing that learned, that risk-taking, mitigation, preparedness, which today with COVID-19, we always are talking about it, be ready, be resilient, and persistent. The ethics, the nursing ethics that we were taught is something that I continuously built it. And one way was to engage both the community of nursing. I'm always proud to say that I worked with the countries to review the code of ethics of nursing, but collectively, so we can widen the horizon. What do we mean by the ethics? And translate it, as Patrick said, to the pragmatic, to the ground every day. Is this what we are talking about, the ethics? So reflection is a lot. Today, COVID-19 has brought us at a junction that we really need to look at our values and principles. And I think as the nurses, we can be the voice, we can speak loud, and at the same time, we know that we will be, whether we are sitting in the comfort zone or wherever we are sitting, we know that we will be asked, why did we say that? Coaching, mentoring are key for our younger generation. I still believe as nurses we can do a lot. I still believe in what I call translating, walking through, practicing what I call in the elements of the human rights instrument, but also the constitution of WHO. What does it mean when you say the health security of nations are the responsibility of both individuals and the states? So if I take as a nurse, I'm an individual, that means there's a community with me working. And then also we have the institutions and the states. And what does it mean in terms of working together and how much we want to invest? We are doing a lot of research, a lot of studies. What is the reward? And for the Academy of Nursing, American Academy of Nursing, as a fellow, honestly, lately I have not been able, twice I paid for my registration, never made it because of the whole dynamics. So how can we have the health diplomacy, the economic diplomacy, and at the same time, the political angle of the different contexts? We should be coming out and speaking and say, we talk about equity, respecting human beings, health equity. What does it mean for us as nurses crossing the boundaries? What does it mean for us as nurses, nursing fellow, to actually go beyond our comfort zone, as it was mentioned? What does it mean, as Patrick said, to bring the voice higher and do not hold only from one angle, look at it from both? And when we throw to say someone at the corruption, I have been one of the key ones in Iraq to say, please wait, let's see what did we do today to say people are corrupt? What kind of mechanisms and education we did? So these are the things that I learned from nursing ethics. Put the benchmark, put the standards, study them, orient the nurses, orient the team. What do you mean by the standards of how to give the care? So to me, these are the measurement of the corruptions. It's easy to throw a message out, but then are we really looking at it from all the angles? And can we have a standard that we can agree upon? Because that's something that I think today can bring the world closer together post-COVID-19 camp. Actually, I will not say post because we are still in COVID-19 pandemic. So when we are talking about countries, Patrick, can we be having the voice as nursing, and I'm very proud of American Academy of Nursing, to push, to advocate that vaccines be given to the most vulnerable, and to push in the year of the International Year of Healthcare Workers, this year, 2021, to ensure that the healthcare workers are protected in order to be giving care to others. And I'm not talking only about hospitals. I'm talking about every single child, mother, elderly, older persons, women, men, vulnerable, refugees, migrants. So these are some of the voices that we can come out and really boldly mention. This is not preaching, my friends. This is not. This is a belief that I am practicing every day. So how can we document this practice? And that is a challenge I have. Fortunately, I'm proud to say that I worked with communities in hardship, and there has been a change. I have worked with communities, with the governments that were considered quote unquote corrupt, but still we put really investing in health insurance that has a coverage for every single person, starting from the vulnerable, then reaching the ones who are most in need. So these are some of the questions that I would raise. Thank you very much for American Academy. Thank you, Dr. Hussein, for moderating. And I really look forward to be with you. I hope in person. However, it seems with this pandemic, we are having some new policies, more policies, even by American Academy imposing on who should be around the table and who should not be. Inshallah, we will together united, we will stop and hold this virus to be circulating and losing many lives, including the nurses' life and frontliners. Thank you.
Thank you. I really want to thank you for your passion, for your perseverance, for your really wishing and wanting the best for the communities you serve, and most importantly, for representing us as a community of nurses on the global stage. This concludes this portion of our session, and we're going to turn it over now to the audience, questions from the audience. Thank you.
Hello again. Glad to be with you. I tell you, I was inspired then when we were recording the session, and I'm more inspired now listening to everybody again. So what we're gonna do, we're gonna have a couple questions. So the first one goes to Erlinda. So Erlinda, let me just make sure everybody's on. Yeah, okay, great. Thanks, because I can't see in front of me if everybody is dialed in, and I see that everybody's there. Thank you. So the first question to Erlinda. So Erlinda, can you talk about how we can support Filipino or Filipino-American nurses working in our healthcare settings? We know that many have families they are supporting back home, and they are also facing higher rates of COVID. How can we create supportive environment for them?
Yeah, thank you very much for the question. It's good morning from this side of the globe. I know it's nighttime over there, but it's we have a 12-hour difference, and I'm so happy to be with you all. I know that that question must have come from a Filipino working in the U.S. Who has been there for maybe the longest time, and I'm happy that you are concerned with what you can do for Filipino nurses coming over. I know that you have a very strong Philippine Nurses Association of America, and I guess I would like to challenge the PNAA to take on that role, to see what you can do to Filipino nurses migrating to the US. I mean, migration is something that we cannot stop. Migration is something that will be there, and it has been there since the 50s, the 40s, and we know that it has already been rooted, primarily because we also have a export policy and export labor policy in the Philippines. So what I can really ask you to do is to strengthen that focus. I know the president of the PNAA is among the crowd now. She just texted me, and I challenge MJ and whoever is coming in as the president-elect that to be more caring and nurturing, see what help you can give to the nurses that are coming over. Because yes, it is true. They come there because not for their self-survival, but for the survival of their entire family. And yes, it is true that the Filipino nurses coming over there are most vulnerable to be affected or afflicted with COVID-19. So please help them. I challenge the PNAA or any other organizations who can assist our Filipino nurses. Thank you for that question.
Thank you, Arlinda. I appreciate your giving us a call to action. So thank you for that. The next question is to Patrick. And Patrick, you spoke about safety and being really threatened in your personal life, personal property, and I think your personal property also, you talked about getting destroyed because of what you are aiming to do. What advice would you have for those who are going against the grain and perhaps feeling that they are taking professional and political risks?
Yeah, I think the most important part of this work, and I think my colleagues could probably agree with this, is the mentoring. It takes a lot of perseverance and a lot of courage to do this work. And that's why I made the comment that you don't usually hear much in the academy about the people who are doing this work in other countries, because we're very quiet about what we're doing, and we have our circles of mentors and senior scholars who advise us and help us understand what we should do when we face difficulties. So I'm constantly negotiating with my mentors situations that are very challenging, and different mentors. It's not like there's one mentor who guides me. It depends on the situation. And so what I would simply say to all of my colleagues in the audience right now is, when we speak about leadership, I would suggest that you look for people internationally who are doing the type of work that you're interested in and offer to mentor them. Because many times these individuals are not going to approach you because of cultural norms and say, oh, will you mentor me? That's not really going to happen in many countries. People are not going to, in Peru, for example, ask you to mentor them. But since I'm also an American, I have no problem doing that. So I would just simply suggest again that all of the folks in the audience, the one thing that you can do to help people like me and people like my colleagues is offer your mentorship, offer to help guide people. And through that relationship, you're actually protecting these people, because people are afraid to touch you. They're afraid to harm you. They're afraid to challenge you in a bad way because they fear the repercussions from that circle of mentors that many times are quite famous in the profession or maybe in other professions. So thank you for the question.
Thank you, Patrick, especially for reminding us of our role and accountabilities around mentoring the next generation of nurse leaders and the rest of nurses in general. So I appreciate that, and I couldn't agree with you more. The next question is for Naima. Naima, in the United States, we know that the largest segment of the nursing workforce identify as female. But you were in positions where your gender often made others question your leadership abilities and probably made them uncomfortable. What advice can you give those of us who are constantly having to prove ourselves because of others' assumptions about us? Appreciate your wisdom at 2 a.m. in the morning there.
Well, good evening to all of you. I really miss being in person to address your question, which I didn't expect. the perseverance that Patrick and mentioned, the consistency, the backup of the mentors, the communication, the backup of the network, and at the same time, continuously, I usually called it grow with pain. Pain will be there. It's not everything is rosy. And at the same time, determination to reach really what we are preaching in terms of giving care, and at the same time, reaching the most vulnerable. So it's a challenge. There is a change. There is now a movement to break the voice. However, we are far away to go. And the main thing, maybe I said it earlier, is how really we translate when we talk about human rights and we see persons instead of colors, gender, status. So to me, that's where we can go as American Academy to continuously call for really translating the human rights instrument and have a benchmark of measure, how much we have progressed. So yes, as a woman, it's difficult in many countries, everywhere, and the leadership, if we look, they will tell you majority are women, but the leadership is different, is imbalance. So gender equity means for both, and treating everyone with lens of equity and equality, I would say. And it's not only for men and women. Sometimes even the minority of the men are also being pushed to the side. So it's actually how we rethink and how we treat human being one-to-one, rather than say women and men, but at the same time not lose the sight that there is an imbalance of treatment of the women who are the majority in the health sector, that they are not being given the position and the voice to speak. It's a continuous support that we need to give. I mentioned already mentoring, backing up, reaching out, and at the same time, realizing that there are elements that sometimes always hurdles, but come back again. You will go down, but still you will rise, inshallah. Thank you.
Inshallah. Thank you. I appreciate your perspective, and it's a reminder for all of us that to remain person-centric in our decisions and our interactions and things where challenges arise, opportunities arise with them, so we have a chance to make a difference. I'm going to just ask one last question as we approach the end of our session today, and this is for all three of you, our esteemed panelists. So, and I would suggest if you take about 60 seconds each, I would appreciate that so we can stay on time. How have you seen, this is the question, how have you seen the pandemic strengthening our global community of nurse leaders or nursing leadership? We often talk about the challenges, but what positive strides do you see? So perhaps, Patrick, if we can go with you first.
I think from my perspective, we've been pushed to the breaking point, like to the edge of the cliff. And I think now we're pushing back and charging forward to the masses of politicians and physicians and other leaders who haven't really supported nursing with more than words. And now the actions are starting to occur. Like in Peru, for example, our National Board of Nursing filed a complaint with the International Labor Organization about the working conditions. And the government was embarrassed. And so what happens? The government starts to respond. But that would have never have happened several years ago. So I would just say that I think that we've reached a breaking point or a tipping point, and there's no other choice than to push through all of the problems that we've talked about and turn those into opportunities for advancement. Thank you.
Thank you, Patrick. Now let's go over to Naima.
A very, very critical question and a timely to be looked at. The behaviors have changed over 2 years almost now with the pandemic. Shutting out the nurses, bringing them up, putting them at the center, but now we are seeing in some countries, again, being pushed away. So our challenge is how to sustain the opportunity given to us. And the other challenge is how to consistently support nurses in different countries that their voice would be heard, beside, as already mentioned, to protect them. And protecting, yes, ILO, WHO, everybody's calling. However, from where I sit, I still see there is a way to build on this opportunity, a long way to go, This is our time now. We have 3-4 months to really position nurses at the policy level and the change level. How to sustain it is something we really need to look at. What happened that again it dropped in some countries? High voice and then suddenly away. Or positioning them at the policy table and then again slowly medicalizations comes back. So this is what I'm observing, comparing some of the countries that I see around me and working with.
Thank you. And last but not least, Erlinda.
Yeah, thank you. I guess the pandemic has shown us the worst and the best that can be seen among nurses and among nurse leaders, locally, regionally, and nationally, and even internationally. But I would just like to talk among us here in the Philippines. So among the nurse leaders in the Philippines, I guess a cohesion. There was more of getting together and trying to see what we can do for our nurses, and that to me is something positive. And so therefore, that collective voice of bringing to the government, bringing to the table what value. I mean, I have always been emphasizing we need to value our nurses, especially during this time of the pandemic. And I guess we are quite successful in that aspect. And with that, I would like to say that election time is almost coming again. It is a tradition that, traditional politics is, of course, something that we do not like. But now they see the nurses and politicians are coming to us saying that these are the things they promise us to do. And we love it. We love it that they have promises to make, because if they break these promises and we put them into positions, then at least we have something to hold on. But I guess this pandemic has shown the true face of the nurse, who we are, what we can do, what our real value, that the healthcare system cannot go on without a nurse, without us nurses. I guess that's the value of what the pandemic has done, and we are succeeding in this advocacy. Thank you.
Thank you. So at this time, I just want to thank our panelists again, Patrick, Naima, and Erlinda, for joining us from across the globe. And want to thank you especially for staying up late to join us this evening here in the United States. You remind us that no matter where Academy Fellows are located, we are all united under the same vision of healthy lives for all people. So thank you, and thank you to our audience for really sharing with our panelists our perspectives on the global value that nurses have. And at this time, I really wish you a great evening and enjoy the rest of the conference. Thank you again.
Now for our closing remarks, please welcome Chair of the Institute for Nursing Leadership National Advisory Council, Dr. Julie Fairman.
Thanks to you all, and thanks for staying. So good evening. I'm Julie Fairman. I'm the chair of the Institute for Nursing Leadership National Advisory Committee. I'm honored to be that leader. And I think this was a wonderful day. I think you'll agree with me. And I think if we could unmute the participants across the globe, we would hear clapping across the globe. So I'd like to offer my sincere thanks to our fellows from abroad for their thought-provoking and engaging insights, and also for accommodating significant time differences in order to be here. 2 a.m. in the morning, that is really dedication, I think. This session provided us with quite a bit to reflect on throughout the rest of the policy conference and in the months to come. To all the dialogue speakers, though, I would thank you for your incredible expertise and your engagement and your time today. And as we've heard throughout the course of the day, the ability to live a healthy life is not something to be taken for granted, as so many in our country and in other countries, as we just heard, are really not afforded that opportunity or outright denied it. Since the onset of the COVID-19 pandemic, it's an issue that the profession has discussed. It's become much more transparent, and we've discussed it with vigor. And I hope that each of you feels a renewed charge and have identified strategies to take actions as leaders in the profession. As Dr. Schwartz has said, you should not underestimate the power of nurses. I would also like to extend my congratulations to the INL Signature Event Work Group members for an incredibly successful event. I know how much time and planning went into this, and I really would like to again thank Hussein Tahan and Janie Heath for their leadership, as well as Karen Drinkard, who is the INL liaison to the Board of Directors. I'd also like to acknowledge individuals who are working on the INL's other initiative, the Courageous Careers Work Group. This group is in the process right now of planning for the development of a series of TED Talks featuring nurses sharing their leadership insights in a way that is candid, vulnerable, and incredibly inspiring. Please stay tuned for that, and there's going to be more on that front. The Courageous Careers Work Group is chaired by Gardia Bannister and co-chaired by Paul Keinert, and its members include Kapiri Ackerman-Barger, Gail Adcock, Bobby Berkowitz, Carol Porter, Patricia Senstek, and Louise Werner. I'd also like to recognize and thank Jenny Chin Hansen, who has worked with me as Vice Chair of the INL National Advisory Council. And I'll now turn it over to her to close us out. Have a wonderful evening.
Thank you, Julie. I'm Jenny Chin Hansen, and I've had the pleasure of working with Julie as Vice Chair of this committee. You know, as we all continue to gather for the rich conversation, both in person and remotely, it's important to recognize that, and we probably really do know, there are tremendous contributions that we're making from our profession. But in the near and the distant future, I think we know we have the challenge, given the context of this past year, of how important it is to double down on the way we go about caring for people, but also preparing our colleagues, for those of you who are in academia. For those of us in policy or practice, we realize there are other kinds of battles that we're fighting for both our colleagues and for our society. So as we do this work, it's so important for us to continue our work as mentors and as mentees, because we learn from one another. And there is this tremendous opportunity, if not frankly, the responsibility to be at the table and to make the tables that will open to others. Because there are many of us who come from different tracks. And one of the things that during this particular cycle, Julie and I have really tried to make very strong as an emphasis, that our careers make very differently, not traditional in terms of the classic way that we contribute, but there are many of us who are doing it differently and coming to the academy with gifts of experience and ways of thinking that will increase our diversity. So we've talked a lot about diversity over this particular cycle for obvious reasons, but it's with that diversity and openness and inclusion that we get a better richness of thought, of leadership, of access, and of regard. So please know that this is one of our commitments that continue here. And regardless of where you are in your career track, whether you're seasoned, whether you're in the mid-career, or whether you're beginning, please know that it's always, no matter where we are in that particular journey, it's important to open the way for others. And so it's important to bring in new people who may not be educated, trained, or practicing in ways that we're used to. But with that richness, we can serve society in a far better way, with a way of decency and regard that I think really exposes what the true heart of nursing is. So I look forward to working with you, as does Julie, and please enjoy the rest of this conference. And we look forward to hopefully meeting together next year. Thank you.
Thank you for joining us for the first day of the 2021 Policy Conference. We will see you here tomorrow morning at 10 a.m.